I think everyone agrees that there is quite a bit of excitement around computing and AI, but there's also some apprehension and a lot of hype surrounding the topics. And as a result, the public and sometimes even the scientific community is not quite aware of the potential and actual things happening on the ground with AI, right? So that's what we're going to be addressing today. And more specifically, what we're going to do today is talk about a very concrete use case where advances in computing and AI are actually driving decisions in the operating room, literally saving lives. Okay, so that's the topic for today. And I'm super thrilled to have Dr. Todd Hollon from the University of Michigan. For the non-expert like me in your field, in the field of medicine,
right?
Walk me through how a typical surgery happens. First of all, what kinds of surgery do you perform? And what are some of the key challenges there? And what happens maybe before this surgery, before your techniques came into the field, how these kind of operations used to be performed?
Right. So I focus on really brain tumor surgery broadly, and we kind of have these two separations between something called skull-based surgery and the neuro-oncology. And they both treat brain tumors, but they kind of have different types of pathology they treat. Like, for example, there's benign tumors like meningiomas and pituitary adenomas, and there's malignant tumors like gliomas and metastatic tumors. I treat both. And, you know, when we're thinking about surgery and preparing for that surgery, one of the most important risk-benefit calculations we do is how successful are we going to be at removing this tumor? Because it makes obvious sense. If you're not going to be able to remove much of the tumor because it's near an important blood vessel or an important region of the brain or an important cranial nerve, you can't safely do that operation. You're going to harm somebody. But at the same time, we do know that removing more tumor helps patients. And again, that's an intuitive thing. If you're leaving a lot of tumor behind, that's going to affect their overall outcome and their survival. So, you know, once we've made that calculation, then it's really about safety, making sure we can get through the operation safely, get the patient through it without inducing any harm, without inducing any new neurologic deficits. And then the real goal of why we're there is to remove the tumor. That's what we're trying to do in brain tumor surgery. And this has been a problem since the beginning of neurosurgery, really at the early 1900s. There was an amazing set of people who started figuring out how to safely operate on the brain. But even then, you know, we were trying to figure out ways to identify tumor versus normal brain. And I'll give you an example in the glioma setting. Gliomas are primary brain tumors. They come from the brain itself. And one of the challenges is that it's not like a solid mass. I remember even when I was in medical school, I was thinking it grows like a ball. And that ball is something that you can just find the edges and then it comes out. The problem is that these tumors, not only gliomas, but other places in the body, they actually grow into the tissue. So they're growing out. You can think that they're kind of putting fingers out into the tissue. And then being able to differentiate that can be really difficult because the tumor infiltration can be quite subtle to identify. And, you know, in modern neurosurgery, there's really two strategies. One is MRI, magnetic resonance imaging. This is where we're doing the operation, and then we think we did a good job, and then we'll stop. And then we get an MRI in the operating room. And that is pretty good at identifying large regions of residual tumor. So if you left a chunk of tumor in, then you know, you'll be able to see it on MRI. That's pretty good, but it's very expensive. You basically have massive multi-million-dollar intraoperative MRI suites. We have two here at Michigan, but it's a lot of infrastructure. And also it doesn't identify tumor that you can't see that doesn't show up on there's just no way you're going to find it. And we know that's a problem. There's a very big body of literature now that says that MRI is not sensitive enough to identify residual tumor. And then the other one is something called fluorescence-guided surgery. This is where we worked really hard to try to find how can we give a patient a fluorescent dye in their vein, and hopefully the tumor will suck up this dye, and then it will fluoresce back at us during the surgery. And there is an FDA-approved fluorescent tracer that we use, and it is a good strategy. We do know that it fluoresces fairly well in regions of dense tumor, but again, we know that there's a sensitivity problem where if there is a low amount of tumor, but still clinically significant,
Yeah.
That means we still know that it's going to put the patient at risk for recurrence. It doesn't do a good enough job.
Okay.
And we're still stuck with this problem. And one of the things I tell my students and tell people when I'm talking about this is it's amazing that we're in the 21st century and we still can't sort this out.
Yeah.
We still can't figure it out. And it's not just a problem unique to brain tumor surgery. The United States government put out a huge nationwide call to try to solve this problem. And they targeted certain cancers. It included breast and prostate, colon, ovarian, and brain to try to ask the scientists across the world, really, please, someone solve this problem. We need to make it move. And, it just came out 2 years ago, and we're starting to make some what I think of as 21st century advances, but there's a long way to go. And we're one of the teams that are working on it. So we have been really working to figure out how can we merge the latest imaging technology that we in our lab and in other places have been developing with the amazing work that's come out of AI and particularly computer vision, because we're dealing with images. And what we now have is the capacity to take very high resolution microscopic images in the operating room, essentially in real time. And that's a real breakthrough because, getting, standard microscopy images. So for example, if you're going to use light microscopy, you need to take that tissue, you need to stain it with some stain like hematoxylin and eosin stain. You need to section the tissue, you embed it in paraffin, and then you put it on the slide and you mount it, and then you have to look at it under a conventional microscope. We maybe had done that in high school or wherever it may be. And that doesn't work. It's far too slow. And also, it doesn't really, it doesn't scale well in the sense that we don't really have the option to stain this tissue. We need to be able to generate images without putting any kinds of dyes or labels or anything on it. So this is something called stimulated Raman histology. And really what's happening is that there's differences in the tissue, for example, in the nuclei versus the cytoplasm, that we can detect using Raman spectroscopy. And a set of amazing engineers, this is a collaborative effort from Harvard and a couple of other institutions, were we able to develop this imager and then spun off a startup making these imagers now. And they're commercially available, and they're being used in brain tumor surgery, but also in breast cancer and lung cancer. And this is an exciting, I think, first step into what a direction, the direction that I think is going to at least be the silhouette of what the final solution might look like. I'm not positive on this one, but we're able to generate these images, and again, there you see them on the left-hand side here, where the patient has a brain tumor, which you can see in the upper left-hand corner. We bring them into the operating room, and then we're opening up this resection cavity, and I'm kind of deliberately drawing the contrast here between what the normal brain looks like and then this residual tumor. But in reality, it's quite a bit harder to be able to see this difference here. And that's why we take these images. And ultimately, we're able to sample the resection cavity itself. So this is where we can either take specimens directly from the tissue here, or we're developing strategies to be able to image in the actual resection cavity itself. And you get these nice looking images. And again, you can see how, it's not like the tumor singularly pops out here. You're just looking at cells. These are just the cells and tissue. And this is where the computer vision comes in. That's so important. It's given, a region of interest, given a field of view, how much tumor is in there. And it's even hard for humans to sort that out now. So we developed a foundation model, and this is a computer vision model, which is more or less able to learn from thousands and millions and potentially billions of instances of these types of images, and be able to more or less just learn the patterns, learn the important descriptive features, sometimes called factors of variation, but basically learn these images in such a way that it can understand them. And ultimately, you're going to ask something of that foundation model. The simplest example I give is, the underlying technology for ChatGPT is something called GBT, just regular old GPT, GPT-5, which is trained on next word prediction. And then ultimately they're fine tuning it for chat. That's
Yep.
where you're saying, oh, I want you to actually chat with a human.
Yep.
And that's the fine tuning step. And then in our case, the fine tuning step for us is, given that you know about all these images, we're going to ask you to then score how much tumor is in this field of view. How much tumor is in this space, and where is it exactly? Yep. And that's what ultimately we did. And what we ask is to give it a score. And in this case, it's a 0 to 1 normalized score. And 1 is it's all tumor. It's all dense tumor. And then 0 is no tumor, normal brain. And then that gives us a numerical value to be able to assess, how, whether we're still in this core region, we're still in this area where there is dense tissue, or whether we're in an area of normal brain. And that is something that we were able to test and to validate. And we were able to show, ultimately, I think I can go to the next slide here. We were able to show that when you test it against the two other things that I mentioned, this is the intraoperative MRI and the fluorescence guided surgery. These are the current standard of care here. When we do that in a kind of prospective fashion, head to head, where we have patients undergo the standard of care versus what we're doing here with this technology, which we're calling vasculioma, that includes the foundation model and the fine tuning, we're able to really beat that overall performance. And the idea here is high performance is up in this upper left-hand corner, and we were able to show that this technology, in this case, it's the purple line, the best performance was able to almost approximate, near perfect accuracy. It wasn't 100% accurate. There's always room for improvement, but we were able to do quite a bit better than the
So it
standard
went from 24% to like 4% or something.
That's right, exactly.
Pretty amazing.
And this is the, I think, we wrote this paper and we wanted to bring it back to patients. You do all of this work and you're talking about AI and you're talking about images and imaging technologies, but ultimately what we're trying to do is help patients. And the question is if you were to use this, what percentage of patients would have a piece of safely resectable tumor left in their head? And that's where that number goes from, like you mentioned, around 25-ish to 4%, which is a huge drop in relative risk of having residual tumor left. And in this case, we're hoping to get that number now down around 0. That's what we're shooting for.
That's the next step.
That's the next step.
More computing, better algorithms.
Yes.
But I do have a little bit of technical question, right? So let's talk about the data you used, right? So you used millions of images. Where did that data come from?
Yeah, it's been a data set that we have collected really for the last 10 years here at Michigan.
Okay.
So any patient that comes through our neurosurgery department, we are able to take a piece of their tumor and we're able to image it. And that's part of an IRB that we have here. That's just approval to use the specimen ethically to be able to generate this data set. And we have.
So all 4 million are from Michigan?
That's right. That's our data set.
Yeah.
We actually have several other centers that we're working with.
Right.
Our two other biggest collaborators are NYU and UCSF, but we do have representative examples from now I think we're up to 4 institutions in Europe, Miami. Again, there's several other places that we're working with. And, the big magic when it comes to foundation modeling is diversity. Yeah. You want a lot of different stuff in there. Yeah. And the good thing about it is the model is able to learn from all of that. And, what we know now with the neural scaling laws is that the more data, the better. The performance doesn't tend to saturate unless things.
Of the 4 million, how many were labeled?
Right. So the good thing about this kind of work is that this patient is going to undergo a brain tumor surgery with us. And ultimately, they're going to get a pathologic diagnosis as part of their clinical care. Yeah. So, if this person does have a glioma or a meningioma, ultimately, that's something that our clinical pathologist will be able to answer for us. So we will get a final diagnosis for the patient and what the tumor ends up being. However, it's not as if we have every single field of view annotated. Right. This is where, these are big, complicated tumors, and we're collecting a lot of specimens. And some of the specimens may contain just normal brain, or they may contain non-diagnostic tissue. There's, necrotic tissue or vascular tissue. And those are not necessarily annotated. Right. And that's why, the technique that we see in terms of training GPT and a lot of the other, quote, foundation models is that you don't want to be too heavily relying on supervision.
Exactly.
Because it just simply doesn't scale well.
Yeah.
And also, if you do have supervision, let's imagine you have all the data in the world and you have annotations to be able to train a model using conditional, cross entropy or regression task or whatever it may be. The problem now is that the model that drops out of that is going to be extremely finely tuned, but just for that one task.
Right.
So you're only asking it to solve a single task,
Yeah.
rather than being able to solve big diversity of tasks or a big diversity of representations that we're asking of it.
Yeah.
And that's really part of the power of doing foundational modelings in the context of both languages.
So it's very clear that a task-specific classifier could be useful in some cases, but there's certainly, for the broad scope you probably not the right fit.
Right.
Do you have any other things to show, or?
I think that was it. Let me see here. Yeah, this was just this is an example of something that we're trying to solve here, and just this will be a good illustrative case of what we're up against here. And this is an example of a patient that we'll see here at the University of Michigan, and this is the brain tumor right here, and you can kind of see the difference between the area that's tumor and the area that's brain. And then this is after a great resection. We see that there isn't.
Did you perform this?
This was not my case, actually, but there's what appears to be that all this enhancing, this is the right area. This is what lights up the tumor. It's pretty well gone. But what we know with certainty is there's residual tumor out here.
Yeah.
We know that there's residual tumor. And the big question is how much, and is it significant? Because what we see is that these patients will go on to recur. They'll recur in specific locations. And the big question is whether, if we were able to quantify the degree of tumor infiltration in this vicinity, would we have been able to predict that this was going to be a high likelihood area of recurrence, and could we have done more resection there?
Right.
So this is ultimately what we're trying to prevent. It's not just the ability to detect tumor, but it's really the ability to prolong survival and hopefully prevent recurrence.
I see an opportunity to do predictive modeling in a dynamic sense.
Right.
Those are the kind of things we do here. But maybe that's a topic for another day.
Sure. So, we're in the process now of trying to get FDA approval for a couple of the models that we have and that we're using with this imaging technology, and it does require, rightly, a setup where you're training the model at one institution, but ultimately the testing needs to be done independently. The testing needs to be done at another center, and that's something that we're rolling out right now. And the good thing is that the imaging technology is fully FDA approved. So that's something that's distributed across the U.S., also in Europe, and that's the exciting bit about this is that the imaging is out there. It's just the sort of AI is the plugin, right? That's just the one thing that we need to layer on top of it.
Yeah, and that imaging, was it also something that was pioneered at Michigan?
It was, yep.
Yeah, can you tell me a little more about that?
Yeah, this predated me by a little bit, and I have to give credit to my mentor here. Again, Dan Oringer and Chris Freudiger are really the two champions of the imaging technology. But yes, it's sort of the original scientific discovery came out of a Harvard chemistry lab. But then Chris Freudiger, he's the chief technology officer at the company Invenio Imaging, they really grew that technology up at Michigan in collaboration with one of our neurosurgeons, Dan Oringer. And then I sort of came along for the ride. But that was, again, just as the AI was developing. So they were really getting all the FDA approvals and infrastructure in place to roll out the imaging technology. And then we've been kind of trying to introduce the AI models into the world.
Yeah, it's very cool. Yeah. So from a computational science perspective, this is full vertical stack, right? In instrumentation, you have the data pipeline.
Right.
You have millions of images that you're getting. You do the foundation model training. And you do the inference in real time. It takes, 10 seconds?
That's right. Yeah, we have an edge compute device that can, again, inference very quickly.
Yeah, excellent. And then there's clinical validation.
That's right.
So it's the entire pipeline is integrated and is here.
Yes.
So now FDA approval is really the only thing
that's right.
is probably stopping you from propagating everywhere. So you're saying right now this is brain surgery, but it can propagate across many different types of cancers.
That's right.
Across everywhere.
Exactly. And this problem is not unique to brain tumor surgery and brain cancer. You know, we do know that there's residual tumor left behind in a lot of different, you know, surgical oncology specialties. And, you know, we just need to be better as a field. I feel like I can say that because I'm in the field, you know, but I just feel like we're coming into an age now where the technology is sufficiently mature that for us to be doing inadequate surgery or suboptimal surgery at a fairly decent frequency, I'm not a fan of that. I think we're letting ourselves and our patients down. So, but I think that the you know, the awareness is there now, you know, across, you know, surgeons and clinicians broadly. So I do think that it's getting, it's improving. I think there was a little bit of stagnation, but I think that it's really gaining momentum.
Yeah, my very last question is, what kind of compute resources did you use for, say, the training your model?
Yeah.
And what kind of resources do you need to achieve the vision that you have?
Yes.
And your collaborators at multiple places have.
Right. So, you know, a big thanks to Michigan because, you know, we do have really two servers available to us. We have something called Great Lakes, and then we also have Armis 2. And we're on the Armis 2 side, and the reason that is for our listeners is because it's HIPAA compliant. So anything that's going to be involving any patient data, we need to make sure that it's siloed. And we were able to use that server to train that.
Yeah, give me a sense of scope. How many GPUs? How long?
Yeah, so it was about 64 GPUs right around there, and we trained it for I think in this case, I think it was about a week. Right around there.
A week on 64 GPUs. What kinds of GPUs?
Yeah, I think these were older school 2080 Ti's. So this was older back in the day.
So you could use a couple of GB200s or something.
That's right. Yeah. So the field has definitely grown up, and the chips are getting better and better as we speak. But yeah, and you know, at the time that was sufficient. You know, and the thing that's interesting about, you know, for you know, the students out there is that, you know, we do hear about these absolutely massive data centers, and we hear about how important you know, large scale distributed training is specifically for language models, you know, because we know about capacity. But that has not quite been as true in vision. We do know that there is some associated boost in performance with model capacity and overall compute budgets, but it's not nearly to the scale that we see with language.
And you're talking specifically about scientific tasks.
That's right.
Like yours, not in general.
Right, exactly.
In general, it's about as bad, worse than language.
Right. So yeah, it's something that I want people to feel like, you know, you can be someone at a university and you want to do, you know, AI, machine learning research, you can still get meaningful things done, right? It's not like you have to be at OpenAI or whatever it may be. So anyways, you know, it's a situation where we have a sufficient amount at the time to be able to get this to work. However, you know, the world is scaling up. And I think that we as an institution need to recognize that in order to maintain pace, in order to make sure that we stay ahead, we do need to be thinking about scaling up and doing more. And, you know, it's not like you train the models once. That's the thing. There's a lot of tuning that goes into it. There's a lot of hyperparameters. There's a lot of experimentation. So in order to be able to do that from a scientific perspective, like you would if you were running a basic science lab, you would never do experiment once, right? You have to do this over iteration. And in order to be able to get that to work efficiently and do it on timescales that are reasonable, you know, we need more, you know. So.
Yeah, good. So I think that would be a good point to wrap up. I do want to encourage everybody to visit his lab page.
Please.
He has a nice app and a few other things you can see.
The
Nature paper is an exciting read.
Yes.
And there's also a whole bunch of new things you're at. So I'd encourage people to look at, what is your lab called?
MLINS, machine learning and neurosurgery.
So please take a look at it. And I do want to wrap up by saying, you know, fast glioma, which is what he developed, is a preview of a world where, you know, deep domain knowledge, AI, advances in optics, and computations are helping surgeons make better decisions in the operation room, right? So this is literally a case where computing and AI are saving lives. Thank you so much for your chat, and thank you again for the amazing work that you and your collaborators are doing.
Thanks so much for the invitation.
Thank you. All right.